start by thanking you. I know it's the end of the day and it's gorgeous outside and you're expecting a snowstorm, so this is the time to enjoy your outside. So I thank you for spending the time in this windowless, almost windowless room listening to me. I'd like to talk, and thank you, Mike, very much for that introduction. It's really a great honor to be here. I've told many people that I've talked with today that while on the inside of Duke, you may see all your warts and pimples and are we doing enough in global health and are we interdisciplinary as much as we want. Actually from the outside, which I'm very qualified to talk about this, you are not. From the outside, Duke looks fabulous. It's amazing what has been accomplished. I know with Mike's leadership, but I also know that Duke was in a place where it was time to really come together around a Global Health Institute. And Mike has shown that leadership and really been a catalyst to bring all that together. When we look from up north, we're quite jealous of what Duke has been able to do and the ways in which they've brought together different disciplines. So it's really been an honor to be asked to come down and talk, and I've learned a tremendous amount even in this short day. So thank you. So the talk I wanted to give was on global health system strengthening, research in action. And I'll give you the outline I've prepared, and then I think I should add one thing to it, representative of Mike's comments. First, I thought I'd give a background and framework for global health system strengthening efforts. Why are we doing this? What do we mean? Why are we doing it? I'd like to then talk about an application of health system strengthening in Ethiopia and a little bit in Liberia, but most of my work will be reflected in these slides in Ethiopia. And then I'd like to talk about research in action and what is the science of improvement. I consider health system strengthening and improvement a science. It doesn't happen by accident. And from my background in hospital administration, I come to it from that there's a way to think about putting together systems that will improve the population's health. It's not about a single person, but the way the system is put together. And that has really drawn me to global health as well, where health system strengthening is a critical competency, I really believe, for people going into global health. But often when we do that, it's about, it's hard to think through what's the research in that. Are you just going to run a hospital? Are you just going to run a clinic? Are you just going to give ARVs? What's the research in it? Because for academics to live a long time in this field and to really develop it and to get grants for it and convince the political environment that this is an important academic interest, we need to understand what the research is. So I'll talk about that throughout, and I hope you'll agree with me at the end that there really is some research to be done, and research, as I would call it, in action. So the fourth thing I'll just put on the agenda, I'll take 1 second to describe what Yale is doing in global health. At Yale, we do have a university-wide initiative. It's not an institute, it's an initiative. It's a framework. More than anything, it's a framework which sets up a multidisciplinary faculty group who has met twice so far. Also has created a postdoctoral training program in global health, which is in full force, and we have 2 postdocs and are looking for 2 more postdocs starting in July. That's been exciting because it's generated a lot of new research and interdisciplinary efforts, because the faculty who oversee the postdocs share, from economics to medicine to policy, etc. We also started a global health certificate program for people who are graduate students throughout the university, and we've started a concentration school of public health for MPH students. The big news is we're trying to get ourselves together to have a secondary major in global health. I know Duke is thinking about a primary major in global health. We hope at least we'll have a secondary major. Again, I chair that committee. It's a very interesting committee in how to bring disciplines together. I would say the most exciting thing about the framework for me is I sort of feel like it is what global health is. How do you work across boundaries? And we feel that just on the Yale campus. How do you traverse the silos in an effective way? And in fact, that ties very well to how I do health system strengthening more generally. So I guess as Mike described me, I sound a little like chaotic, putting my finger in little things here and there, but actually it all makes sense to me that this bucket of things I do hang together. Okay, so any questions before I get started? I guess one thing I can say is if you have a question, please ask. Mike told me just talk straight through and don't let you guys ask questions, but actually I do a lot better if you ask questions, and I assume you won't mind if I say I can't answer that now. We're going to move on because you're taking too long. So feel free if you have a burning question to ask. So some background. Clear background, I bet everybody in the room knows this, the tremendous increases in foreign aid for global health in the last decade, fourfold in U.S. aid. And this spending really, I think probably many people in the room have recognized this, the spending has really been dominated by disease-focused spending. But this makes some sense, particularly HIV/AIDS affecting about 32 million people, TB, you see the malaria numbers here as well. And if we look at why decisions were made, it's never that people in political powers or people in economic powers are being ignorant or not smart and they just decided to focus on diseases instead of a larger system. It actually makes a lot of sense. And the slide, I think, shows it quite well. On the y-axis, life expectancy, on the x-axis, time. And then each line represents a different country. And the lines that are dotted represents the country with very high HIV prevalence, Zimbabwe, South Africa, Botswana. And the lines in the same region of the world with that are straight lines, upward sloping, Madagascar, Senegal, and Mali. These are the low HIV prevalence countries. So if you were a policymaker in 1990, 1995, starting the late 90s, what would you do? You'd say, well, this is incredibly correlated. This huge reduction in life expectancy is incredibly correlated with HIV prevalence. If we really want bang for buck, we've got that US mentality, what are we going to do? And how are we going to get political excitement about something? We're going to say we have to deal with this issue. It makes a lot of sense that this is how our funding particularly evolved. But as we look now, there's been some mixed impact of this. Some tremendous successes. 2 million people, and these are probably dated somewhat, 2 million people on antiretroviral treatment, 70 million bed nets distributed, 74 million malaria drug treatments, 4.7 million additional cases of TB detected and treated. Huge amount of impact when you think about those numbers, and that's where the target was. Nonetheless, a fair amount of concerns that the spending is not achieving actually its full potential with continued preventable poor outcomes, like this enormous rate of mothers dying per year in childbirth.